So we're going to show you 3 videos about the CNIS situation and really trying to let you know that structured clinical training has changed in the 21st century. Now, our current structured courses, our CNIS skills courses, have 3 basic objectives. One is thinking skills. We do this through interactive lectures and Socratic quiz questions. Management skills through case studies using the surgeon as patient or role playing. And technical skills where I use simulators, synthetic, biological, and hybrid, as well as the operating room with specific patients. This is how we've been doing it for the last 22 years. During those 22 years, we've developed 12 structured courses, 2 non-clinical courses. We've established 10 skills labs in Africa, and quite a few more than 30,000 African learners had participated in our courses. 10,000 grade 5 pupils have taken our nonviolent conflict resolution course. You can see more about this on our website. What's our new direction? We don't want to change the principles of our courses, but we want to digitize all 12 skills courses. So we're going to continue the current ESS program. The methodology we've been using for 20 years is still valid, and it keeps the courses fresh and clinically current. But our new direction with Project MOS, which has received unprecedented public and media attention, is to digitize.
Over the past 20 years, Dr. Lett and his colleagues at CNIS have been training healthcare workers on surgical skills in Africa.
Well, CNIS was set up as a response to the frustration of trying to take care of patients in Africa personally. The risk of a mother in North America is 1/10 of that of a mother in Africa. 13% of Africans will die an injury death. And I realized that I just couldn't do it all.
Dr. Lett came over from the Surrey Memorial Hospital to meet with us. It's nice that we're just across the street. He showed us a game that he wanted to create to teach surgical training in Africa.
We are faced with the issue of an increased demand for what we do with diminishing resources. With Project MOST, we are looking at putting the thinking skills, the management skills, and even some of the decision-making parts of technical skills on mobile applications.
Fast forward 6 months and we're building software for Ethiopia, Rwanda, and Tanzania. This digital simulation training is targeted at surgeons, GPs, and nurses in Africa so that people with head injuries can be treated more quickly. With CNIS so far, we are working on avatars and some of the user experience.
Currently, we have teaching projects going on in Ethiopia, Kenya, Uganda, Rwanda, and Tanzania.
And we'd like to accelerate that by a factor of 10. We're scheduled to do 5 of the digital simulations, and we believe that will impact 2 million patients.
By building patients on the mobile apps that the learner has to interact with means that we can now have active learning on a mobile app. So the ultimate objective here is to accelerate learning, to improve learning, and to expand the learning opportunities throughout the African continent.
Using mobile technology, they can scale, go across Africa, Rwanda, Ethiopia, and Tanzania this spring, and make a real global impact. And we're going to help them do that.
Our initial objective with Project MOST is to pilot 1 course. We've chosen to develop and refine the digital delivery of the traumatic brain and spine injury course, since this course is limited to 1 day. But TBSI has all of the elements of the 3 or 5 day CNIS courses, so it will be a true pilot. We have concurrent funding from the Bondi Foundation, both for the current active course in the standard format, as well as for the digitization and field testing of the new course. I'd like to demonstrate the navigation of our app. You can see how the app would appear on your tablet or cell phone. There are 5 buttons, including case studies, tutorials, quiz questions, lab setup, and a toolbox. The first button that we'd look at is the quiz question, where we will have Socratic questions, which are a standard part of all CNIS courses. There are a few examples of the mechanics we will use in this app to deliver questions on initial assessment, traumatic brain injury, skull fractures, spinal fractures, and spinal cord injuries. In this first example, the learner is presented with brain injury classification and must match them with their definitions. As a PowerPoint presentation, this would be a deadly dull, sleep-inducing presentation. But in this situation, the learners will be asked to classify traumatic brain injuries on their own. Another question would be situated following questions about primary and secondary brain injury, and subsequently, as shown here, the learner would be asked to categorize them accordingly. In the case of traumatic brain injury mechanism, the learner must order them according to their frequency and the magnitude. If the learner gets anything incorrect, they will be prompted to correct by highlighting those areas that are out of order. We can see a subdural hematoma. The learner is asked what they see. If they were to pick epidural hematoma, we would show them an image of an epidermal hematoma and then ask them to try again. We have case studies. Case studies are an integral part of all the CNIS courses. But in the digitized version, case studies are built around a 3D avatar with a set of injuries which will prompt the learner to manage the case. Tutorials, including, in this case, the Glasgow Trauma Scale, the Kampala Trauma Score, the issues of pupillary assessment, the process of intubation, resuscitation, the specifics of log rolling the patient, and cricothyroidotomy will all be available in the Traumatic Brain and Spine Injury course. These tutorials are more didactic than the quiz questions, but involve the opportunity to digitally review or practice specific activities. Learners can move in and out of tutorials during case studies, but the flow of the case study will only be interrupted as required. The learner can also review the tutorials independent of the case studies, and the tutorials may be encouraged by the debrief at the end of the case study if the learner clearly needs to review some specific topics. We want to make this app complete. One of the things that technology does not serve well at this point is hands-on learning. In the app, we have a button for teachers who will be instructed on how to set up the skills lab. In the case of TBSI, there are 4 stations. The 3 dry labs, radiography, craniotomy, and spinal injuries, and the 1 wet lab where they practice craniotomy and depressed skull fractures on a biological model. Thus, the TBSI app will completely reflect the standard TBSI course. At the end of the day, we expect the learner to go back to their community to contribute what they've learned to their patient. In addition to what they have learned, they would have access to a toolbox of items that would be useful to them in their future practice. For example, a GCS calculator and a KTS calculator. The toolbox will be expanded as we complete the TBSI course and as new modules within most are developed. Okay, so you've been introduced to Youssef and Tima, so let's carry on and look at a case study with one of them. The case study involves Tima, who has been presented to a district hospital. I'm the general surgeon at the district hospital, and she is unconscious as a result of a violent altercation. The only bit of data we have on her in initial presentation is her temperature. I come in and I do as I would do to any patient, is speak to them. I look at her chart and say, Tima, Tima. She doesn't respond. I see some bruising on her face and it makes me concerned that she has a head injury. I tell the nurse to put on a cervical collar. I want to check her airway. It seems to be clear. And I am concerned that her level of consciousness is not normal, so I want to protect her with a nasopharyngeal airway as a temporizing measure. I move on to the next part of the primary survey. I check her breathing. She I want to put on her pulse oximeter, and as I do that, I automatically add oxygen because a traumatized patient always needs supplementary oxygen. She's breathing now, she's oxygenated, or at least her oxygenation is improved. We listen to the chest, there's nothing of great concern there, and so we move on to circulation. Her blood pressure is low. I'm not happy with that. We start 2 large bore IVs, and you can see that she responds to that with an increase in her blood pressure. Now, we know that head injury does not cause low blood pressure. Where we move on to disability, her AVPU level, getting a bit more precision. Not only is she not verbalizing, but she only responds to painful stimulus. So we check her pupils and we find that the left is larger than the right. At this point, we can say we have a hypotensive patient with a head injury of significance. I'm not happy about the cause of her hypotension. We look over her entire body, and there we see a large laceration which is bleeding profusely, which is clearly a part of the cause of her hypotension. We move back to the circulation, and we put a pressure on that wound. And you'll see as we do that, her blood pressure goes up. So now we have 2 large bore IVs with pressure on that wound, allowing her blood pressure to go back. So after we've done that, the pressure on the wound, I would go back to exposure because I'd had a general survey and I'd found the laceration. So obviously we respond to that. But we need to roll the patient over and we need to check under her arms. Those both were normal. We move on to secondary survey. The first focus on secondary survey is the head. I look at the scalp. We see minor bruises and some lacerations. The neck, there doesn't appear to be any wounds, and there's nothing to be visualized on the face. I recheck the pupils because clearly this major concern here is head injury. I want to have a better understanding of her neurological status, and we calculate the Glasgow Coma Scale using the calculator that's in the app, and she has a Glasgow Coma Scale of 7. This is not a good situation. The Glasgow Coma is out of 15. I previously didn't intubate the patient, but now I think that this is absolutely mandated. So we go back to airway and we intubate the patient. I check for the airway, make sure there are no foreign bodies, suction her out, do the chin lift, and then remove the nasopharyngeal airway and intubate the patient. So now we have a packaged patient. She's intubated, cervical collar, 2 large bore IVs, and pressure on the bleeding wound. We don't have a CT scan, but we can X-ray her skull, which reveals no abnormalities. The X-ray of her neck shows 7 cervical vertebrae. We visualize the cervical vertebrae on the thoracic vertebrae, all of which are normal. Because she has a head injury, we want to look at evidence for a basal skull fracture. So we would examine her tympanic membranes, we would look behind her ear to see if there is a hematoma, and we would check her nose for evidence of cerebrospinal fluid leak. We check her pupils again, we shine the light in the eyes, and we see the left, even though it is enlarged, does respond slowly to light. The right responds to light normally. So we have a serious head injury, but we have a salvageable patient. We can assess the overall trauma status using the simplification of TRIS, the Kampala Trauma Score, which is used in Africa and actually in rural Quebec as well. She's 40. She gets 1 point for that. She has 2 serious injuries, so she's a multi-traumatized patient, and so she has 0 points at this dimension. Her systolic blood pressure is 70/40, which scores her 1 point of the possible 2. Her respiratory rate is 15, so she gets the full 2 points. She's only responds to pain, so she gets 1 point out of a potential 3 points on the AVPU neurological status. So we have a Kampala trauma score of 5. At this point, the patient is packaged, ready for transfer for definitive care. We have options in this app. The patient is at the district hospital, therefore they could go to the operating room directly. Actually, this is their best choice. If you have the capability, this will give most rapid management. If you transfer the patient to the ICU, in this app, the patient dies. The delay results in her demise. If we transfer the patient to another institution, again, the patient dies. This emphasizes the need for urgent craniotomy. We go to the operating room. At this point, we can then choose where we'd make a craniotomy incision based on the choices of incision. I don't remember which pupil was affected, but I can go to the patient log. It indicates it was the left pupil, so I'd go back, make the incision on the left side. Usually we talk about making a reverse question mark incision, so I would choose the final choice as the correct one. At the end of the case, the learner will get a debrief. The debrief here needs some work. It's a little bit boring, but it does summarize that the team was successfully transferred to the operating room where a craniotomy was performed. So in addition to this, I would think in the future the debrief might mention what they didn't get done and the order of how the debrief is presented would be improved as well. So we've had an example of a case study similar to the case studies in all the CNIS courses. We're using an avatar to teach. It's interactive rather than just pro or passive. And we have further developments as far as placeholders and activities are concerned, which will make this app even better over the coming weeks. Where are we going with the MOST project? As mentioned before, the plan is to digitize all our courses. In 2017, we will complete the TBSI pilot and roll out the TBSI digital program throughout Eastern Africa. Our next step in 2018 is to digitize operative obstetrics. Meet Zeta. This poor lady is going to have all the causes of antepartum and postpartum hemorrhage as well as obstructed labor throughout the digitized operative obstetrics course. From 2000 to 2020, our objective is to upgrade the current modules, the TBSI and Zoom, the Zeta's operative obstetrics module. As well, we want to digitize trauma team training, fundamental interventions referral and safe transfer for midwives, and fundamental interventions referral and safe transfer for clinical officers. The big question always is, well, where are they going to learn their technical skills? Currently, we will still teach hands-on skills in the laboratory and the operating room. Virtual reality for open surgery has made recent progress, especially with steel-on-bone simulation. But currently, it's not acceptable for soft tissue surgical simulation. However, there are still 80 years left in the 21st century. How can you contribute? We're going to have a quarterly review panel. You can sign up online. Watch for updates on our website. Thanks very much.